Good day to you all, and welcome to what is our penultimate webinar. We're quite extraordinary. We are on our 9th seminar in a series of 10 webinars. And welcome to those who have accompanied us from the start, that is since October, and those who join us for the first time. And as for newcomers, can I just point out that those who would like to review or view some of our past webinars, we are very happy to announce we have a YouTube site, which is part of the King's College London website, and we'll have the address, the link in the Q&A box. So please give us your comments and feedback and so on, critical or otherwise. We'll be most appreciative of that. I'm Maria Jaschak. I'm a co-initiator of a recently established research program, Female Bodies in Patriarchal Inscriptions, hosted by King's College, the Arts and Humanities Research Institute. And we are extremely grateful for the tremendous support we've been given. And it is thanks to this support we have the wonderful, indispensable presence of Taylor, who's going to lead us through all the technical difficulties which Teams provides. And many of you know what Teams really does do and doesn't do. It's not terribly interactive. And that leads me straight away to a very important point. We are so appreciative of you joining us for the webinar. Unfortunately, it's not a most interactive software. And we hope that you bring your questions, your comment into the Q&A box as questions arise to you, with simply pointing out, please identifying the presenters you wish to have the questions addressed to. So the Q&A box is vastly important, and we'll be reading from this and feeding your questions to the presenters right at the end of the session. Because we have such a rich program today, the format is slightly different. We will have the 6 presentations, which includes one panel first, and the Q&A session right at the end. My welcome is, as I said, on behalf of a small team of conveners. Toby Levin von Gleichen, she'll be presenting today, so she's one of the presenters, and Comfort Momo. And dear Comfort, we hope that you get well very, very soon, very quickly, and you have full recovery of your health. Today's webinar presents a very interesting, we consider under-researched, still under-acknowledged area of sexuality and female sexuality. That is, with our focus on FGM in that webinar series, explore FGM in connection with, as the work is so much cross-cultural work, intersectional work, the difficult, problematic area of female sexuality embedded in so many diverse contexts. The title of the webinar theme, Sexuality and Pleasure, Beauty and Pain, Female Genitalia as a Site of Ambiguity and Intervention. The discursive focus we have adopted is that of the highly successful clitoral reconstruction, the surgery accomplished by Dr. Pierre Foldes back in 1988, that is restoring a great deal of the sensitivity, receptivity, and capacity to feel pleasure, sexual pleasure. So the question that arises for us, why is it, given that facility, that there has been such a modest uptake of this particular reconstructive surgery? So today's speakers, and we are extremely honored, we are very, very happy to welcome today's speakers from so many different disciplines and methodologies with such expertise to probe sexuality in various ways, whereby this whole contested area of female genitalia becomes a site of intersecting forces, centering on notions of gender ambiguity, on genital beauty, on medical intervention and the politics of verification, identity formation, on infliction of patriarchal inscription, however also seen as individual choice, as empowered self. And lastly, on pain, self-harm, and the addictive nature of self-harm. With presentations to our mind demonstrating how intersexual nature of sexuality requires the most meticulous scholarship, evidence-based research, serious cross-cultural, interdisciplinary and cross-disciplinary debates, and the most innovative methodology and use of sources, always guided by principles of justice, equity, and receptivity to the women at the core of all of that investigation, the women who matter. And with this, I turn to our first presentation. Is it truly easier to make a whole than to build a pole? Feminist reflections on a chapter of genital surgery on children with ambiguous genitalia. And this presentation is given by Dr. Marion Huberscheid from the University of Kassel, the Department of History. Marion, if I may hand over to you. And unmute, please. If you could unmute.
Idea. So do you see my slide?
Right. I'm hearing your voice now and waiting for your slide to occur, to share your content.
So you don't see my slide yet. So I'm waiting for a word that you can see my slide, because so I shared my...
Do you want to try and share it again? It hasn't come through. Sorry about that.
Okay. Now?
Yes. It's coming. Perfect. Marion, it's wonderful.
Okay. First introduction for myself. I'm a trained physician and medical historian, and for the last 25 years, I've been working on deciphering the mental attitudes governing medical practice, be they colonial, racist, or patriarchal, so intersectional. I was involved in female rights movement, especially on FGM, and that's how Toby and me know each other for about 30 years now. I wrote my thesis on German medicine, 19th century clitorectomy, so the question of hysteria and masturbation. And for the last 7 to 5 years, I've turned my attention to intersexual born people and their experience in the second half of 20th century. So this is the trajectory of FGM, human rights movements to intersex movement. I changed my title because the correct citation is really not truly. So this is now here we are. Okay. So in the 1990s, so 30 years later than the FGM human rights movement, the development of awareness for genital mutilation of intersex children started. In North America, there's Cheryl Chase to be mentioned with the Intersex Society of North America. And for Germany, which is the place where I live and where I act and where I mainly perform my research, it was by then Birgit Reiter, now Michel Reiter, with the working group on violence in pediatrics and gynecology. They claimed that the altering operations on the external genitalia of children with ambiguous genitalia are to be considered as genital mutilation. So this human rights issue was raised, and now there is a large community of human rights activists working on that. Due to the fact that I'm a physician, and I'm sure that everybody should know, but I don't know if everybody knows. I just want to give short explanation about what is intersex, so that you don't mix it up with transsexuality. So intersex, this term derives from the strong dichotomy of male and female, boys and girls, men and women. An ancient term was hermaphrodites, and medical field was still searching for dichotomies, for differentiation possible by the look of the external genitalia, internal genital organs, not the capability of bearing a child or breastfeeding a child, secondary sex characteristics, chromosomes, or hormone levels. So the gender is not mentioned here due to the fact that it's biological thinking. Intersex is a rare condition. Activists claim that one in 2,000 children born has kind of these conditions. Medical expert put it in 1 to 4,500. The current term in the medical field is D is the acronym for disorders of sexual development, or differences, which is the more friendly term. What I will mention today to you are only 3 of these different conditions. I would call it conditions because there are some more, some less, have a pathogenic impulse on the life and the body of a person. So CIH is a congenital adrenal hyperplasia. This condition was known since the end of 19th century, but it could only be treated started in the 1950s with the application of cortisone. Then you have chromosomal abbreviations, and although we think that we have chromosomes since ancient times, we could only depict them since the 1950s. And then there is this condition of severe hyperspadia in conjunction with cryptorchism. Sorry for these medical terms, but I will give an explanation in a minute. So clitoris hypertrophia, hypertrophic clitoris, or a hyperspatic micropenis. So this is the question of size. And it's always the question, is it size that matter or function? And the difference between female and male is not the size. If you look on a newborn child, it's a question of the connection, the relation of the erectile tissue to the urethra. So in female, the clitoris is separated from the urethra, and in the male, the urethra passes through the erectile tissue. Clitoridectomy was performed when they thought, or when somebody said there is a hypertrophic clitoris. So, but this meant, and this is now special for the FGM community, to cut off the glands. So the spongy body, the erectile tissue, was still kept in the body, and these surgeons who operated on the children, they knew about the size of the clitoris. They knew that it was more than a glance. Vaginoplasty, I just mentioned here, I can't focus on this, but this is a severe medical procedure where these intersex children, especially with CIH and some other conditions, suffered from that they got a vagina, and vagina kept opening. So penis reconstruction had the goal that the boy have a normal urinary stream. So this is a citation from a website from a urological surgeon, a normal urinary stream, and that they can urinate in a standing position. But this is a cultural habit and not a biological need. Please keep in mind, in this whole reconstruction field of children with ambiguous genitalia, especially in the second half of 20th century, especially in, for example, the United States or even Germany or Switzerland, that there was a big fear of homosexuality, which was a pathological condition. And doctors there was still this argumentation in the discussion which sex the child should be operated upon was the fear of producing a homosexual child. So what I do is I give you a brief sketch of the 1950s. And the first I want to cite is a Swiss, Zurich-based psychiatrist, Manfred Bleuler, who published a big work on endocrinological psychiatry, so the conjunction of hormones and psyche. And he says on girls with CIH, the help that best suits their needs is frequently simply to protect them from becoming outcasts or even persecuted, and to allow them to live in the busy, immature, primarily asexual field of interest they dwell in. Surgical interventions are therefore secondary because he thought they don't need to have sexual intercourse. And his preference was on the cortisone treatment by Wilkins. I come to this in a minute. But he considered the special needs of individual cases that they need to be considered. A very friendly position. The more famous actor in the field is John Money, a psychologist with a migration background because he was born in New Zealand and then went to the States. He was called, or an employee at the Lawson Wilkins clinic, employed by Lawson Wilkins, who was the pediatrician who was the first to work with his children with CIH. And he started his scientific career as a psychologist and sexologist in the 1950s. So he is known for this John Joan case, but I focus on the early John Money. And in a publication from 1972, he still stated, and I quote, stated in non-technical terms, the lesson of embryonic anatomy is that it is easier for nature to make a female than a male. The familiar embryonic and fetal rule is that something must be added to produce a male. Quite possibly the same paradigm may apply also to gender identity differentiation, though there is as yet no conclusive proof of this hypothesis. So there is no proof of this hypothesis because this thinking of that the male is the superior and something where you needed to add something on is now overcome, and we know that we have different impulses needed either for the male or for the female. More important are the Hopkins protocols for like treatment guidelines, but not in the guidelines we know from today that the decision about the sex of a child should be taken and operated upon before the second birthday. And this protocol, this guideline came out of the experience they had not with children who were under the age of 2, but older, and their experience and their problems. So this citation, which gave the title to my talk, I first stumbled upon in an article by Birgit Reiter, the intersex activist. She cited this in 1996, and she cited a German pediatric surgeon who published an article in 1982. So this was a 14-year-old citation. And I quote Bolkenius here because he put it in a historical perspective. This indication for constructive masculinization, genital plastics, needs to be seen as an innovation, so the surgical production of a penis. As in general, the opinion was dominant that in case of doubt, it is A, easier for surgeons to create a female genital, and B, it would be easier for such an individual to live in later life a female sexual compromise, end of quote. So this female sexual compromise is live a female life, but don't have the female function of giving birth to a child. So there's a clear reference to the John Money and Anke Erhard. And the point is that girls look simpler than boys, but a woman's body, female body, is more complex than a man's body. And what works in here, I think, is, I just need to mention Judith Butler, that you have this peer group affiliation or the belonging to your to your gender, that the physicians were mainly male, and so they knew how males act and interact in their peer group, like piss out the bonfire. But what they miss are, for example, the menstrual talks that girls in puberty have. So do you have already started? How is your pain? No, I can't join the sports class today, and all this. I give you an example from Zurich from the 1950s. I found it in the patient files from the pediatric clinic. It was a child born in June 55, birth weight 2,900 grams. This is all right, but this child was severe sick because it was suffering from malnutrition. It couldn't nutrify well, so it doubled its birth weight by the second birthday, and this is usually the case when the child is 4 months old. And the external genitalia looked special, so like a hypostatic penis, but the chromosomes were male. The physicians couldn't make a prognosis about the secondary sex characteristics, but they pressurized the parents, especially the mother, that they should make a decision. She should draw a decision about the sex of the child. The mother wasn't present in Zurich, so she wrote letters. There's a written conversation, and this is good for medical historians, so you have sources. And this is the child, little one, but it's a bad picture, sorry for that. The mother wrote in 1957, regrettably, it is not possible for me to tell or to predict whether a man with a non-functioning penis is a priori unhappier than a woman with male chromosomes and without uterus and ovaries, or maybe even unhappier than a eunuch requiring lifelong treatment with female hormones. I really do hope that you have quite a bit of experience with similar cases and that you can therefore offer some advice. End of quote. So this intelligent, university-educated and eloquent mother has a more broader view than it is seen in, for example, John Money or the others. So the points I want to make is quickly that biology is not congruent to society. So sex is not gender. We all know that. And that gender expectations we have, they rely on the same sex mindset. When for a man, an imperfect man is better by the 1950s raised as what he thought is an imperfect man, this is a woman, than to be raised as an imperfect man. And there was no possibility of thinking that the person should make up its own mind about their own decision, make their own decision. Doctors were confronted with high expectation. Please give me an advice. You have the experience. And the doctors, although they hadn't the experience, they said, I can fix that. And they had this large self-esteem due to other developments in the medical field, that they thought, okay, we can do it. And they were addressed as half-gods, that they can fix it. But it is easier to say, I can fix that, than to confess, sorry, I cannot help, I can't change, but I can stand by your side. So I can make something right that was wrong before. You have this dichotomy again of right and wrong, but who defines who is right and wrong? So conclusion, there's the hidden agenda of the male physician also in the intersex treatment field. There are power issues or self-determination and there's a discourse needed, and we have this discourse now in the 21st century with the medical society and the ones who are affected. And the ones who are affected are not only the children who were treated, but also the family who was affected or their relatives, and the discussion with the society at large. There needs to be a review of the decision-making processes, and we're into this right now. And maybe we figure out that wait and see is better than act and react, and wait and see was probably in the 1930s and 40s. What the doctors said, they said, well, we don't know how this child will develop, so let's wait and see. And they didn't operate at that time. So now we have experience to draw from, so let's do it. Move from the physician-centered view on the body and on the simple appearance, bodily appearance, to the society-centered general, to the individual-centered perspective. Every person is different. So, and keep the child with it and the prospective adult in the center. So, and here are my cookies. Thanks for your attention.
Thank you, Marion. I can't think of a time when the questions you've raised about science and the place of science in relation to other kind of perspectives and agendas would be more important than at the current moment. And you've raised many questions. I already see in your Q&A box, yeah, a number of issues to be raised. But this will have to wait until the end. Thank you, Marion. I will quickly move on to our next presentation. The Global Quest for Genital Beauty, Female Genital Mutilation, Cutting versus Female Genital Reshaping. And the presentation is given by Oluchukwu Lavis-Abiora, a Friedland postdoctoral research fellow, University of Witwatersrand, Johannesburg, South Africa. Lavis, if I can ask you to take over.
Yeah, thank you very much, Maria. Once again, welcome everyone. I'll be presenting my presentation is titled Female. Sorry, I need to share my slide. Oh yeah, okay. Oh yes, thank you. So my presentation is titled The Global Quest for Genital Beauty and Female Genital Mutilation / Cutting versus Female Genital Reshaping. Now, some of us might be wondering, especially those that might have joined this symposium today, you might be like, why all the talk about the female genitalia? Why all the talk about the female external genitalia? Why all this? What are we talking about here? Now, I would like to let us know that the female genitalia, even though it's referred to as a private part, females across the globe have continued to be directly or indirectly influenced to pursue some certain standard of beauty or normalcy for their external genitalia. Now, a Dutch study that involved a large convenient sample of women reported that 95% of the participants frequently examined their labia minora, and almost half of the participants found their labia appearance to be imperative. Now, another study in the USA examined a sample of hospital-recruited pre- and postmenopausal women. Reported women's age did not impact on their perception of a normal vulva, and postmenopausal women in that study were more likely to consider FGR if cost was not an issue. Now, when I talk about FGR, I'm referring to female genital reshaping, which can also be called female genital cosmetic surgery. And then when I mention FGM, I'm referring to female genital mutilation, or some call it female genital cutting. So whichever terms is fine, female genital cutting or female genital mutilation. And then we have female genital reshaping. So this is the reason why we are talking about the female genitalia, because it's private, yes, but still women are concerned because there are several expectations from the society of the ideal or normal female genitalia, and this has led to several practices. For the operational definition, we already know that female genital mutilation refers to all procedures involving partial or total removal of the external female genitalia or injury to the female genital organs, whether for cultural or non-therapeutic reasons. That is according to the World Health Organization. Then the female genital reshaping, as I mentioned earlier, which is also known as FGCS, that's female genital cosmetic surgery, is the removal of the vaginal mucosa or the modification of the healthy external female genitalia. Now, it's good to note that health is not just about disease. Health state of complete physical, mental, and social well-being. And because of this definition of health, FGR could therefore be a necessity when female surgery would lead to an improvement in the quality of life of the client. The first presenter has already explained some of the terms that are involved in FGR, and these include labiaplasty, labial-majoral rejuvenation, hymenoplasty, vaginoplasty, and clitoral hood reduction. All these are involved in female genital reshaping. However, in this presentation, FGR will be discussed with emphasis on the modification or alteration of the female genitalia without an evidence of organic problems or disease. So this will be the context. We'll be discussing FGR in the context of where it is done without an evidence of organic problem or disease. Now, now the debate about the comparison between FGMC and FGR has been ongoing. There are several write-ups out there about FGR and FGMC. Some say it's happening in different socioeconomic environments and various reasons. We will see that. However, this presentation, the aim of this presentation is to create a line of thought. Remember, this is the 21st century, and in this century, people ask why. I have a 6-year-old that will always say, "Mommy, why?" When you say, "Don't do this," or "This is the way it should be done," the next thing will be, "But why?" So now we have FGM, a standard definition by WHO for FGMC, and we have a definition for FGR. But now we want to look at the two terms and the two practices and compare them. We want to see why FGMC, why FGR, what is actually driving them? Is there any junction at which they meet? We've done a couple of work on female genital mutilation here in Africa, and based on the experiences, on the data we got from the field and the available literature on female genital reshaping, which is still FGCS, that's female genital cosmetic surgery, we are now comparing. We are like, is there any juncture? What is driving these two practices in this separate socioeconomic context? So therefore, the purpose of this presentation is to discuss the quest for genital beauty as a junction for, or a meeting point of, FGMC and FGR. This discussion will be underpinned by the theories of ethical relativism and self-perception. Now, I'll quickly talk about the theory of self-perception. Theory of self-perception explains that we interpret our actions the way we interpret the action of other people, and our actions are often socially influenced and not produced out of our own free will as we might expect. Therefore, the action of requesting for FGR or FGMC for oneself or another female could have been preceded by an interpretation of the appearance of one's genitals or the genital or that of another female as flawed, discomforting, or needing some modification, whether for cultural or aesthetic reason. Now, the theory of ethical relativism explains that people judge behaviors or values to be good based on whether it is acceptable in their community and culture. Now, I would like to remind us that culture simply means the people's way of life. So when I mention culture here, don't just see it as culture as in a rural place or somewhere. It's simply the people's way of life. Therefore, whatever the culture or the way of life of the females perceived as good in their community is accepted and ideal by the females. Now, let's quickly look at, is there really a quest? Remember, the title of this presentation says, it's talked about the quest for genital beauty, FGMC and FGR. Now, is there really a quest? Remember, a quest means a pursuit. When there is a quest, there's a pursuit, there's a desire to achieve something. Now, talking about FGR, that's female genital reshaping, according to the British National Health Service, the number of labiaplasty interventions performed in the UK increased 5-fold in 9 years, from 2001 to 2010. A similar increase was reported by the American Society of Plastic Surgeons. And then there was this report also that according to the British Society for Pediatric and Adolescent Gynecology, 266 labial reductions were performed in the UK between 2008 and 2012 on girls under the age of 14. And remember, FGR, even though performed in very good, well-equipped medical facilities by qualified surgeons, is not completely without possible complications. Like every other surgery, it can also have complications such as post-operative infection, hematoma, asymmetry, and all those. Please pardon me if I'm using medical terms, a lot of medical terms. Now, the quest for female genital mutilation, is there a quest for it? Yes. Actually, there has been a report that a decline has been reported. Sorry, for female genital mutilation. A decline has been reported. That is good, but the fact still remains that 200 million girls and women alive today have undergone some form of FGMC. And the rise in international migration has increased the number of girls and women living in various diaspora populations like North America, Europe, Australia, who have undergone or may undergo the practice. So there's the report that we have the report that there's decline, and yes, that is true. But the truth is that because of rise in international migration, FGM is now a global concern. And also because there's a population boom in the countries where FGMC is prevalent. So the decline that we are seeing might not be exactly as expected. So this implies that FGMC is still ongoing, and the demand for FGR is also quite high and increasing. Many reasons have been presented on literature for FGR and FGMC, but in summary, FGR thrives with the promise of improved genital appearance, sexual pleasure, and function. But according to American College of Gynecologists, though the current evidence base that FGR provides all these benefits is limited and of questionable quality. Now, several studies have documented evidence about poor or negative perception of the genital as a strong factor that promotes FGR. In fact, one publication I read about FGR by Sprigg and Gillam 2016 reported that clients might emphasize issues of dysfunction or emotional issues, and they might emphasize it to a surgeon, whereas the reason why they are requesting for FGR is actually because of poor perception of their genital. All to make the surgeon to agree to do FGR. Now, FGMC thrives with the promise of a neat and clean genitals, which qualifies the female for marriage and ensures chastity, cultural identity, and so on. However, all these promises are hinged on giving the female a certain ideal genital beauty or appearance. I hope we are seeing a line of thoughts concerning FGR and FGMC. Yes, they are parallel. They have several differences, but if we look critically, we'll see that they are trying to meet somewhere the quest for genital beauty globally. Look at this diagram. I think this summarizes what I've been trying to explain so far. If FGMC is an arrow and FGR is another arrow, parallel arrows that are moving on their own on a straight line, and now we decide to cross them to see if they will meet at any juncture, we will have something like this. FGMC is not prevalent in developed countries. Client's consent is not always obtained, mostly performed in non-medical practitioners in non-medical practitioners and patients' home, banned by governments. Many governments could be aimed at reducing sexual urge, and sometimes performed on the girl child. FGR is rarely performed on the girl child, aimed at improving sexual satisfaction, approved by governments of many countries, performed by trained surgeons. Client's consent is always obtained before it's done, and prevalent in developed countries. But if you look critically, you will see that they meet at this juncture. A quest for an idealized genital beauty depending on the environment where the female is. Now, before I round up, I'll quickly present to us the motivating factors for this quest for genital beauty. I'll now be discussing FGMC and FGR together. Now, the first motivating factor for this quest for genital beauty, this pursuit for genital beauty, is one, culture. Culture. Remember, I said culture is the people's way of life, not just something that is peculiar to one rural place. Given the changes in the cultural desires and the enthusiasm to have a specific appearance of the female genitalia, it is not surprising that an increasing percentage of females demand for various types of female genital reshaping so as to normalize their genitals, as they might have seen on media or pornographies. While at the same time, females in many developing countries have continued with the practice of FGMC so as to conform to their community's ideal female genitalia. Maybe in their communities, the clitoris is not always there, or maybe in their communities, the labia is always sewn together. That's for developing countries. Then they will now, once a child gets to a female gets to a particular age, they will mutilate the genitals to have that appearance that is acceptable in their community. Now, another female in the developed country watches a pornography or sees something on the media and is like, oh, this is a model, I want to have this particular genitals, and she goes for female genital reshaping because she's now feeling like my genitals are not normal. The clitoris is so big, or this one is shooting out, the labia is large, and the person decides to go for genital reshaping. This shows that culture, the environment, has a lot of influence on this quest for genital beauty. Another motivating factor for this quest for genital beauty is the influence of peers and relatives. In the developed world, the partner or and other friends might criticize the female's genital and tell the girl, oh, your clitoris is shooting out, your labia is too big, and all that, and she begins to feel like, oh no, I'm not my genitalia is not normal. And she decides to go for FGR. In the developing world, the circumcised mother and relatives might begin to talk to their daughter that she needs to be genitally mutilated so that she can have so that she can be chaste and neat and have the ideal or the normal genitalia that every other woman in the community has. And so the girl is taken for genital mutilation. Now, another motivating factor is ignorance and confusion, as well as the activities of healthcare professionals in promoting FGR and FGMC, whether directly or indirectly, influences this quest for genital beauty. Now, in conclusion, the argument that FGMC and FGR are manifestations of the global quest for genital beauty might be a giant step towards rethinking, reconceptualizing individual, society, and cultural norms and ideals without bias or prejudice. Remember, I started by telling us that this paper came from an imagination of why. Why is there any meeting point for FGMC and FGR? This quest for genital beauty is not just about self-determination or autonomy, but are influenced by factors such as culture, which we've discussed, the influence of relatives, healthcare workers, ignorance, and confusion. The question still remains that we live in a very gendered world. We live in a gendered world, and the female keeps being influenced by the society she lives in. Thank you.
Lovers, thank you very much. We live in a gendered world, truly. You've certainly made an eloquent case for viewing this in a highly, complex and problematical and multi-perspective, multi-voice narrative way. And there are questions already in the Q&A box, and we'll come to that later on. Thank you, lovers. Splendid. You also kept to time. As time is of the essence, and I move straight to the next presentation. It's a panel, but I gather only two will be presenting. A panel which the focus is clitoral restoration. from Farafenni to Paris, and there will be explanation as to that particular main title. And the speakers are Nenes Boja, founder, director of the Inter-African Committee in Norway, also a radio talk and TV show host, and Toby Levin von Gleichen, known to a great many to you. She's a visiting professor together with me here at King's and associated with the Hutchins Center for African American Research at Harvard. So if I can hand over to you straight away, please. Thank you. And please unmute.
Yes, I just unmuted. Nena is concluding the speech, which I will begin, and she will explain, I'm sure, what we mean by from Farafenni to Paris. I want to welcome everyone on the flip side of the screen. Thank you for coming. As time is of the essence, I'll simply start with the story of Senait, not her real name, an Eritrean student I taught at the University of Frankfurt in a course on FGM and film in the 1990s. Senait spent hours sitting in my living room, exhausting my video collection. Like many women cut in babyhood seeking clitoral repair, she had long felt some sort of loss, some incompletion. And why? After 20 hours with the visuals, it finally clicked. Quote, because it was done when I was 2, she explained. I don't remember, but I've always sensed that something wasn't right. Now at last, I see what I've lost. Not unlike Isa, who celebrates her birthday on the anniversary of restoration. I'm no longer foreign to myself, she says. Slide 2, please. My patients, many patients of Dr. Foldes have explained themselves in similar ways. Quote, I'm empty, said one. Ashamed of my body, said another. Adding that, quote, all the friends I've informed hope to be restored as well. Atifa, whose post-operative recovery was slow, persisted in exploring a newfound sexuality until she too could claim she was, quote, happy because the doctor returned what had been seized. I am intact. That's a trajectory like Awa's. Quote, I didn't feel whole, Awa says, the term at once raw and powerful. Others say cut, amputated, different. I wanted to erase the indignity of my absent clitoris, Falila states. And for all of them, reconstructive surgery is the reason their ears twitched that day when on TV or in the papers, they heard you actually could get it back. Often the operation is chosen in an instant. I found Dr. Foldes' address on the internet, Awakwita notes, but I didn't believe the claims. Excision was supposed to be irreparable, but I hurried off to see him anyway. Generally, thanks to the unbelievable, discovered in a magazine, on TV, or in the advice of a friend, they notice in themselves a desire for repair that had long existed. So they make an appointment. Slide 3, please. As Foldes assures his professional biographer, prize-winning novelist Hubert Prolongeau, reconstructive surgery is born of sympathetic listening. And in fact, primary among all motives to restore was desire to recuperate the organ. Other things, such as pleasure, would be mentioned later. Not that pleasure isn't important. One 64-year-old living in the USA shared her niece's jubilation. Admitting resignation to an imposed state accepted only with ambivalence, she lends an ear to the younger woman's, quote, doubts, decision, operation, and joy to find herself whole once more, releasing emotions that she, the aunt, had thought packed away forever, like tears, but also longing. I know it must seem absurd at my age, but I'm interested again. It's the hope that's returned. So how does Foldes do it? Briefly, he removes the scar, revealing richly innervated tissue underneath, for the visible protrusion is only the start. The clitoris extends far into the body, leading to the 4th spinal vertebra, and from there sends impulses to the brain. What really happens when it's cut? Here I defer to University of Toronto neuroscientist Gillian Einstein, who confirms that cutting neural innervation to the vulva causes the brain and spinal cord to respond in a manner similar to, quote, any loss of neural targets or inputs. Einstein regrets the dearth of holistic studies acknowledging FGM's effect, quote, on the entire body via neural rewiring, calling this omission, quote, startling when one considers that the vulva is highly innervated by both sensory and motor nerves. Cutting the vulva must include cutting nerve and muscle, components of the nervous system. It becomes, quote, all the more chilling considering that loss of targets may lead to further retrograde degeneration in the brain, a known result of ablating these organs in cancer victims and their loss in multiple sclerosis patients. Quote, currently there is no information about how the breasts, legs, corpus cavernosum of the clitoris, and pelvic representations are related to the external genitals in female somatosensory space, or how to map in relation to each other, end quote. Now, Einstein published this in 2008, but the situation, although improved, has not shown significant progress since then. All this said, the question remains, should the amputation be reversed? What are the emotional costs? Let's be clear. Undoing FGM is not without peril for both patient and doctor. In Saint-Germain-en-Laye, I asked Foldes about personal risk. Unbuttoning his collar to reveal a 4-inch scar, he said, in general, if you oppose violence against women, you can expect a little trouble. The defendant of the status quo had entered his office with a knife. That nothing beyond a flesh wound had occurred testifies to Pierre's sang-froid. He talked the assailant out of pursuing his hostile aim. Yet many activists receive death threats. Efwa Dorkanu clarifies the pervasive threat of harm by describing a drama that Somali women wrote, telling, quote, the story of their lives. Efwa had been counseling them. In the play that they wrote, an arranged marriage has brought an infibulated girl to London where, given British medicine's ignorance concerning the need to defibrillate brides, women turn up the radio, TV, and whatever else makes noise in order to undertake an opening cut, quote, right here in the UK by themselves. Yet Dorkanu adds, the authors caution her never to produce the play in genuine fear for their lives. Dorkanu concludes emphatically that indeed, women can be killed. Opposition to FGM can be lethal, and the choice to restore demands courage. Slide 4, please. Aware of leaving a myriad of issues for Q&A, I now turn briefly to additional pioneers of reconstruction in various forms. First, please meet Nigerian-German Dr. Dan Manode, a plastic surgeon working in Aachen whose operation is far more extensive than that of Foldes. O'Day restores the vulva using plastic surgical techniques. When co-presenting with O'Day, I presented on emotions expressed in memoir and fiction. I've seen in photos the finished product as close as can be to an unharmed organ. Conscientious, he strives to satisfy the patient's desire for beauty. Slide 5, please. O'Day, though based in Aachen, sometimes works with the Desert Flower Clinic, named after Warrisdiri's memoir, in Berlin. Their chief surgeon is Cornelius Strunz. Founded in 2013, the clinic offers a myriad of services, and its staff has been trained by Dr. Foldes in applying his method. Slide 6, please. Another student of Foldes is Dr. Marcy Bowers, a transgender surgeon working in the San Francisco area. She and I met in 2016 at the first U.S. Summit on FGM in Washington, D.C. Of note is the clarity with which Foldes, O'Day, Strunz, and Bowers oppose the performance of excision in the first place. It has been argued that clitoral restoration is not a strategy for ending the practice. For why stop if what is cut off can be restored? We disagree. For those whose courage permits them to reverse their loss are among the most vocal campaigners. Slide 7, please. Thus, to conclude, when Nena visited Dr. Foldes, novelist Jeannie Cortum and I were with her. Jeannie produced a narrative focused on Nena, but enhanced by interviews with other patients she met in the Well Woman Clinic. Most were present at one of the center's regular speakouts because they were satisfied clients, but one had a tale that pulled at Jeannie's heart. One woman in Paris, tears leaking from her large brown eyes, told me because she had chosen restoration, she was exiled by her community and now is contemplating getting cut again just to avoid feeling so alone. Slide 8, please. Yes, as mentioned, choosing restoration in defiance of communal norms can imperil patients, but far louder were the voices of courage. Victims like Nena are fighting back, telling their story. Even as she is wheeled into surgery for restoration, hazy with sedatives, Nena is militant. The removal of my clitoris was a crime, but I will not be a victim, she says, as she disappears behind swinging doors. It's a sexual revolution for the circumcised woman, a revolution of the clitoris. And that comes from Jeannie's paper. Slide 9, please. As Mawa tells it, once realizing that her best part had been snatched, she sought the physician who wrought miracles by restoring smiles. Slide 10. Thank you. I turn it over to Nena.
Wow, that was lovely. Thank you, Toby. Thank you, everybody on the panel. This is such an honor to be a part of this amazing day. I'm not gonna waste a lot of time. I will just read briefly about a journal that I took. I'll just quickly read an extract from the daily journal that I took of my experience with Toby, Jeannie, and Pierre. Actually, the part that I'm going to read is a little bit about the control after the whole operation. And this is going to be featured in the book that Toby and myself are working on, which is the Clitoris Dialogues, the distance between Farafenni and Paris. And why the title, The Distance Between Farafenni and Paris, is because Farafenni is where I was circumcised and Paris is where my clitoris was restored. So that's why we have the title from Farafenni to Paris. I'll just quickly go into it again. This operation the operation has done more than restore a part of my body. It has restored my mental health in that it has awakened me as an individual. It has awakened a part of me that has been castrated. I'm enjoying the rush of blood into this part of my body under this healing process. Oh, sorry, wait. Sorry. I'm nervous.
It's quite all right.
Yeah. And I'm enjoying the rush of blood into this part of my body under this healing process. A part of my body on which there was little or no focus unless during sexual intercourse. I know I'm no longer afraid to write sexually explicit material for the Gambia Daily on orgasms, when I had been scared thinking I'll receive a bombardment of abuse. Instead, the article was well received with over 21,000 readers and great reviews. The restoration of my secret of joy has been given birth to a new woman who now can express herself through literature as well. I have definitely been reborn. It is now 3 o'clock. I guess we'll be boarding soon since the flight leaves at 4. I might say that the painkillers and the writing have made the wait bearable. As the airport lounge begins to fill up, I feel a twinge of excitement as I make the final leg of the journey. I'm debating what has to be my gift to this man who has given me back so much. I thought of the music cassettes he normally gets from each of his patients, but I feel I must give him more than that. I have to think about this well and ensure that at our next meeting he gets something back. Maybe him and Toby should be nominated for the Nobel Peace Award in Norway, along with Emma Bonino and all of the great, amazing activists that work in the field of FGM. This man is a great man indeed. My follow-up appointment at the Institute in the clinic was anything but boring. I arrived half an hour before the time given by taxi. My lack of French left me sitting almost an hour as I sat in front of his office, patiently waiting, and nobody said anything to me. Something clicked in mind that maybe I should have reported to the secretary first. So I reported to the secretary, and within minutes, I was ushered into Foldes' office for my inspection. The inspection, like everything else, was very professional. I do not think that any woman will meet Foldes and feel he has been anything but professional. Within 5 minutes, the inspection procedure was over, and here he was writing a prescription for me for a cream to apply to my new clitoris once every morning for 6 weeks, and to continue for the next 6 months to gently caress it until it reaches its full working capacity. It was as complicated and as easy as that. I felt happy, and he was happy that I was happy. When asked what he wanted as a gift, he said nothing but that I must speak and inform people about his work. It has now been more than 3 years since this life-changing experience. My clitoris is a living, functional organ that has taken a life of its own. I feel a rush of blood as it reacts to events and circumstances as it pleases. The distance between Farafenni and Paris has been liberating in the name of Foldes and clitoral restoration. Thank you for listening.
Well, thank you both, Toby and Nennis. And Nennis, let me tell you, your voice here made an important contribution. And I love the way you made reference to that clitoris that's taken on a life of its own. Yeah, yes. This is absolutely fantastic, wonderful. Thank you both very, very much for this. And I'm sure there will be, quite a bit of discussion at the end of this. But I move on hastily to the next presentation given by two filmmakers, and they want to highlight and look more closely at the side of this highly innovative restorative surgery being done, and that is FGM survivors' quest for wholeness, on making a film about the pioneers of the clitoris reconstruction. And the two filmmakers are Sebastian Krüger and Juliet Wallace. Now, I have to ask Juliet, is Sebastian around, able to give the presentation, or will you do it?
Apparently he's still having problems, so we were wondering, it depends on what the structure necessitates. If you'd like to go to the next speakers first, if not, I can do the presentation. Either way is fine. But Taylor's saying that she's still having some troubles. She suggests going to the next speaker, but I'll leave that up to you.
That's fine. I think we can move on to the next presenter then, and come back to you at the end and see whether Sebastian sort of managed his way into.
Sure. If he doesn't manage, then I'll take over. It'll be a bit shorter, but I'll
okay. All right. We'll come back. Thanks. Thank you. And to our attendees, hang in there. Stay with us. We move on, therefore, to a really, really interesting presentation on the right to bodily autonomy. That raises a lot of issues here. Do women have a right to choose FGM cutting and FGCS? female genital mutilation, cutting, FGM. And this presentation is given by Annemarie Middelburg, the Tilburg University Law School, and founder of the Middelburg Human Rights Consultancy, and Dr. Rifat Karim, plastic surgeon, founder, director of the Klinik Asterven, and expert in post-FGM reconstruction. So if I can hand over to both of you, Annemarie and to Karim. And please unmute yourself.
Thank you very, very much. I'm just double checking. Can you see my screen?
Yes.
Okay, perfect. First of all, thank you very, very much for the invitation to speak today. I think it has been a wonderful, wonderful webinar. It's really, really nice to really see so many interesting presentations, and I'm very excited to present here today. Our presentation is on the right to bodily autonomy, and we will address the question, do adult women have a right to choose for FGMC and female genital cosmetic surgery? My name is Annemarie Middelburg. I have a PhD in the field of FGM. My background is in international human rights law. I work as an independent consultant for the UN, for NGOs, and I still work at the University of Amsterdam as a lecturer. And Dr. Rifat Karim is a plastic surgeon, and he performs many different types of operations on the female genitalia and male genitalia. He performs clitoral reconstructive surgery in the Netherlands, so he learned the technique from Dr. Pierre Foldes as well, and he has operated more than 50 women in the Netherlands. He's also performing labiaplasty and other types of surgeries. So what we thought would be nice is to first have a quick introduction into the right to bodily autonomy from a human rights law perspective, and then have a short discussion about the differences and similarities between those types of operations. So let me introduce to you first a movement in Africa. This is called the All Women Are Free to Choose movement. When I was working on a background paper for a high-level expert meeting of the UN, I came across this movement. And it's women in Sierra Leone, in Gambia and Kenya and Liberia. They are connected and they claim that they have the right to make choices for themselves regarding their own bodies, cultural practices and lived experiences. What is really interesting when I did a bit more research on these types of movements is that the constitutions of these type of organizations explicitly refer to female genital cosmetic surgery. So the popularity of labiaplasty and clitoral reductions suggest clear aesthetic, hygiene and comfort benefit that Bondo and Sunday leaders have proclaimed for centuries. And that is, of course, really interesting. I added the website of the movement, so if you're interested, you can find more information there. But this was not the only development that made me reflect on the right to bodily autonomy and the right to bodily integrity. In Kenya, we currently have the case of Dr. Tatu Kamau. I'm quite sure that many of you are familiar with this case, but for those of you who are not, this case is about a female physician from Kenya. She also held a number of high-level positions at the Ministry of Health, and she filed a case in the High Court seeking to have FGM legalized for adult women. She actually states that women should have the right to freely choose for FGM. And therefore, she also claims that the legal ban on FGM, so FGM in Kenya is, as many of you know, criminalized. She argues that this legal ban on FGM is unconstitutional. She says that females, especially adult women, should have the freedom to consent to the practice and have the right to be cut under the supervision of a medical practitioner. And there's one quote in particular that I would like to share with you, and that is this one. She says, if women can decide to drink, to smoke, women can join the army, women can do all sorts of things that might bring them harm or injury, and yet they are allowed to make that decision. Women can also make the decision for female circumcision, and once she has made that decision as a woman, she should be able to access the best medical care to have it done. It's really, really interesting because in this case, there are so many issues and things at stake. First of all, whether or not the law is constitutional or not. But also, second of all, if women have a right to undergo FGM. And then the third issue here at stake is whether governments should provide or whether or not FGM should be institutionalized. So government should provide the best medical care to have it done. So that actually made us think about the right to bodily autonomy. And it's really, I always enjoy working together with people from different backgrounds. And since Dr. Karim performs many different types of operations for a really, really long time, we started to have discussions about where to put a limit, what should or should not be allowed. But let me first go into the definitions, because what exactly are we talking about when we talk about the right to bodily autonomy? Well, you have the right to bodily integrity and bodily autonomy. And very often, even in academic literature, they are used interchangeably, but they are conceptually different. And that's something I want to highlight. The right to bodily autonomy is the right to make free and informed choices or decisions in relation to your own body. And the right to bodily integrity is the right not to have one's bodies touched or interfered without one's consent. And the ability to give free and informed consent about decisions regarding your own body follows from the principle of self-determination. Then I quickly want to move to the human rights-based approach. So the right to bodily autonomy and integrity are connected with many other fundamental human rights. For example, the right to liberty and security of the person, the right to privacy, the right to freedom from torture, inhuman and degrading treatment, and the right to the highest attainable standard of health. As we all know, FGM is recognized as a harmful practice. It's defined as a form of violence against women under the CEDAW Convention. We know that FGM has no health benefits, but many harmful effects, and women are suffering from the consequences throughout their lives. If we then look at FGM and female genital cosmetic surgery. Female genital cosmetic surgery is accepted in Western societies and not seen as a harmful practice or a violation of human rights. However, if we look at the WHO definition of FGM, strictly speaking, cosmetic surgery would fall under the definition of FGM. Why? Because it's a procedure that involves the departure or removal of the external female genitalia for non-medical reasons. And this has also been acknowledged by the UN agencies involved, because already in the interagency statement of 2008, you can find that it has been acknowledged that some practices, such as genital cosmetic surgery, actually fall under the definition of the WHO. And therefore, many academics argue that perplexing contradictions arise from qualifying FGM as a human rights violation while upholding permissive standards regarding FGM and female genital cosmetic surgery. Now, the similarities and differences has already been highlighted very, very nicely by Lovett, the second speaker. So what I would like to do is to have a very short discussion for the time that we have remaining with Dr. Refat Karim. As said, he also performs clitoral reconstructive surgery, for victims or survivors of FGM in the Netherlands, but also labiaplasty and other cosmetic surgeries. So, Dr. Rifat Karim, I have a few questions for you. And my first question is, where do you draw the line? So do you think that women do have a right to undergo FGM or not? What do you believe are the main similarities and differences from your experience and from your perspective? Could you perhaps reflect on that?
Can you hear me, Anna-Marie?
Yes, very clearly.
Yeah, thank you. Well, the biggest problem is it has to do with your own ethical, medical, and personal boundaries. That is very important. For me, the boundaries are relatively simple, but complex. I do believe that everyone has a right, man or woman, to have surgeries done if they want to. But there are few crucial things. Do not do harm. I will not excise the clitoris. I will do a labioplasty. I will do a clitoral hood, but in an adult woman, I will not touch the clitoris. But it's very strange. In other contexts, I'll do it because I also operate transsexuals.
Yeah.
And in that context, you do touch the clitoral body. I think that the biggest problem with FGM, in my opinion, is that we forget that this is a procedure that is done to children.
Mm-hmm.
And they cannot consent.
Mm-hmm.
And if we talk about adulthood, I once wrote an article about circumcision in male, and what you don't know, there are severe forms of circumcision also in men, where you transect the penile body, and those are real severe forms. The form of circumcision that we do in men is a very simple skin resection. And if you ask me that, if a woman who is of African origin asks me for a labioplasty, I will do that. But you could see that as FGM. So if you say that, yes, people and women may have something done in the context of FGM, it is possible, but I will do a very mild form. I will not cut off the clitoral body. But if they say, doctor, it makes me feel better, and I would like to have a little bit of circumcision of the clitoral hood skin, that is possible. So what it makes so difficult is that I think that in the context of Africa, I understand the wish of talking about that FGM has similarities with cosmetic surgery, because I think that we have discussed that before, but not in this group, that there is some prejudice, white prejudice about this kind of surgeries. And I do think that the reason that we call it mutilation and not cutting, because if you say it's cutting, you could have a better conversation with each other, because at the end, I do believe that the parents did this to the children because they thought it was good, although they did the wrong thing. And so it is very complex in that issue, if you can still follow me, that I do think that people have the right to choose what they want, but the context in which it's happening, the peer pressure which is going on, it is really important to look at that aspect too. When young girls come to me for labioplasty, and in our clinic we do not do that under the age of 18, children are not operated. You always have to look at the context. But basically, you could say that people have a right to choose, but as a doctor, you have your ethical, medical, and your personal boundaries, and also your how do you call it, your oath as a physician, that you will protect the patient from harm.
Mm-hmm.
So
could you also then quickly reflect on the point that was made by Loveth about genital beauty and what is considered beautiful? You already mentioned social pressure and the influence of culture and the cultural context. How do you, if you compare cosmetic surgery, for example, labiaplasty or a clitoral hood reduction with FGM, how could you reflect on the point that was made and how women should look like, what is considered to be beautiful? How do you see that as a surgeon?
Well, for me, beauty is always contemporary. Every culture, every time has its own beauty, and that is how it is, because now people, the beauty of labiaplasties are very to cut off as much as possible, and that's contemporary. So beauty is contemporary and defined by the culture and the place you live.
Mm-hmm.
But I thought it was a very nice lecture from Lovett, but I think the idea of saying it has to do with beauty, I understand, but what for me is the point where because it was still about children, and if we want to now talk about that, we should do this in adult women, and if they want to have something done in their genital area, then we have to redefine also FGM, because I think what you said, that in the law it looks the same, but you have to redefine it, because I think that in aesthetic surgery, the clitoris is never touched.
Yeah, the clitoral body.
Body.
Yeah.
And I think that makes a very important part of this discussion. Mm-hmm. That if I will go with the idea that it has to do with aesthetics only for adult consenting women, not for children, because then we say children's, you should never touch them, never operate on them and this kind of subjects. Then we'll have to change a few boundaries about what is what, because as I told, in the male, we do only a skin reduction and we do not chop off the penis. So
yeah,
there is a discussion. I think there's
no, and it's a very interesting discussion and very complex one. Unfortunately, we are running out of time, so I need to wrap up. But I'm sorry.
Okay, Anna-Marie, it's good. Okay.
Yeah. So, thank you so much, Dr. Karim. Perhaps also good to know for the people who are listening now is that we are currently finalizing an article that we write together about clitoral reconstructive surgery. So we did a analysis of all existing evidence and research. We have visited the clinic of Dr. Pierre Foldes in December last year as well together. So this is also a topic that we're working both on. But there's no time to reflect on that now. So I would like to give back to the moderator of this webinar. Thank you for your attention.
Thank you, Anna-Marie and Karim. I mean, I can't thank you enough for throwing up all the difficult kind of questions that need further discussion and probing, and are so relevant when I think, of the recent discussion here in the UK that came up with Tavistock Clinic and gender reassignment, and, the kind of interventions made that's now considered by the court as having been too early, as the age of consent, that cannot be under the age of 16, raising these difficult issues. What is the age of consent? But it's relatively straightforward and simple to give that an age, a cutoff point of age. But there is a more difficult issue when it concerns adult women. What is informed consent? What might be considered as an old feminist kind of perplexity? False consciousness. The idea, is sympathetic listening involving, a degree of education? Is that education, or is that, degree of also superimposition, of particular, cultural norms? Well, I think we will have plenty to discuss, and resonating very much with your particular presentation and this wonderful debate that you had, the discussion that you, dialogue you engaged in, is our next presentation. And I think that we will move to Louise Herman, and waiting then for, the issue that's come up with Sebastian Krieger's lack of access to resolve itself. So if I could ask Louise Herman to prepare herself, and this is a presentation on women, girls, and self-harm. And that raises, additional kind of issues. Tragic, increasing, often invisible. Louise Herman is the managing director of the Women's United Nations Report Network, with a focus on our, particular symposium theme. Louise, if I can ask you to please take over.
Thank you very much. I will note that WUNRUN, the Women's UN Report Network, is now in our 18th year, and we address, based on a UN study, the oppression, the human rights, and the empowerment of women and girls all over the world. And so what I'm going to talk about today is what I call a masked violence against women. And that is self-harm. It's tragic, it's increasing, and it's often invisible. What is self-harm? It is self-inflicted on women's and girls' bodies. Some view it as a way to numb the pain. And examples of self-harm are self-cutting, eating disorders such as anorexia and bulimia, overdosing on drugs, opioids, fentanyl, hair pulling, harmful behaviors on social media, intentional personal pornography, burning, self-battering and intentional bruising, and even suicide attempts. So this is hard to hear. And yet, with the COVID pandemic and the lockdowns, an increase in women who are suffering violence has exponentially increased. And we're on the 16 days campaign of violence against women, and yet it's off the charts. And one form of violence against women, a pervasive form in modern society, is self-harm. Limited research is available on self-harm, but it indicates that poverty and debt may be driving forces for female self-harm. Further analysis shows that broader ranging factors for self-harm can be family violence, low self-esteem, failed relationships, berated body image, and we live in a culture of beauty. Stereotypes, poor mental health, physical issues such as disease and disabilities, academic pressures, homelessness, criminal justice engagement, prostitution and human trafficking, alcohol overconsumption, depression and desperation, and overall insecurity. The self-harm may additionally be involved with a male person, and an example is a pimp insisting that a prostitute have his specific tattoo symbol. Self-harm may be intersectional and compounded. It can occur regardless of geographical location, generation, racial diversity, sexuality, and other societal factors. Part of the year in Italy, and I'm speaking to you now from the US, so I'm giving you a little bit of a bilateral lens. I had a personal experience in June that really brought forward to me the secretiveness of self-harm. I had a hanger in a clothes closet that fell and created a long tear on one of my arms. And I'm rather slender, and this became very bright blue. It bled some, but it didn't go away. And this was June, so it was warm outside, and it was hard to cover up my arms. And people know that I'm involved with the UN and the EU, and you know that I'm a serious academic lady, a researcher, but I had women who would pull me aside and say, looking at my arm, "Are you okay?" So that it's somewhere in the back of their ideas is that maybe I did this to myself intentionally. And when it happened to be that way, that it was an accident and got so much attention, it brings forward again the issue of self-harm. Self-harm is exceedingly private. This is not something we talk over coffee in the morning with our friends or at the lunch with colleagues of our work. It is so private. It is associated with shame, with stigma, discrimination, victim blaming, rejection, and social isolation. And sometimes these never go away. Self-harm may be one incident, but often it's compounded multiple times. It can be a crisis for both physical and mental health, and can indeed even be life-threatening. Self-harm is increasing, and with violence against women and all the mental health challenges of the current era. Yet you don't see self-harm in the headlines. You see very few studies. What are some of the behaviors? What are some of the reasons that a woman will be drawn to self-harm, to cut herself or bruise herself? Is this to numb her inner pain? To manifest self-esteem issues? Or, as some spoke on this webinar, to have bodily control, bodily autonomy? If I hurt myself, at least I'm in control. Self-harm may be multi-generational, and it is a tragic reality across the lifespan of many females. But a young woman, as in Italy, who's under lockdown, who can't find a fiance, who's frustrated, who may go to school online, and her mother and grandmother will say to her, "But when are you going to get a fiance? When are you going to get married? When are you going to have a baby?" And this young woman cannot go out and meet people easily at bars and social institutions because of COVID-19. because of the laws that the government imposes during this restrictive period. So this young woman could be considered very vulnerable. She may well indeed pull out some of her hair. She may binge eat or drink. But she is trying to cover pain. Online violence against women and cyberbullying has increased the potential exposure of women and girls to abuse that can lead to self-harm. One Run, our program, just hosted a webinar in Europe with the Special Rapporteur on Violence Against Women, who had written a report about online violence. It's a new frontier. It's a new front line. And we need to be attentive to how many young women who were never digital before, and even older women who are closed in, are subjected to images that can lead to self-harm. When we focus on the intersectionality of self-harm and other women's rights issues, we are really noting body image, but also very unseen intersectionality, such as refugee status, such as migration, such as internal displacement. All of these conditions can unsettle the stability of the mental and physical health of a female person. A recent movie made in France was entitled Mignon, and I'm going to try to show you the cover of that. Desktop. Maybe Taylor, you will excuse me. What I'm trying to do is show you Mignon. Mignon is a movie made in France, and it means sweeties. And this movie gives an on-screen visibility to the struggle of preteen girls trapped in cultural struggles on the path to womanhood, and especially for the leading role, who is from a Muslim Senegalese migrant family. She's confronting porn-inscribed pressures and social acceptances in modern digital France. On one hand, the lead role, Amy, has the strict religious family pressures, and yet she wants pure social acceptance and attention from boys. So indeed, this is a fragile age. Every age is fragile. But a girl who's not born so beautiful, so popular, so included, may well be a potential victim of self-harm. I think that you can bring me back.
Yes, consideration of time, Louise, yeah, that would be good.
I just have a few more things to say because I do know that we are limited on time. I could refer to a few of the very limited studies or research on self-harm, and they are in 3 different countries. There's some in Australia, there's some in the US, and some in UK, and primarily and most recently in the United Kingdom. I would like to say one short paragraph from Johnny Crowder, who's the founder of Cope Notes. It's a program, he was himself a survivor of self-harm and founded this program online, which is really growing, where people can privately get support. Quote, one commonly misunderstood aspect of self-harm is that the individual engaging in the behavior enjoys pain. This may be true in some cases, but in my experience, it was more about control. Other people's circumstances and the world at large can hurt us in ways that we as individuals cannot control. So he is saying that there is this linkage between control of my body, even if I'm going to hurt myself. Sad but true. We want to make young women of all ages feel healthy. And that's why patriarchal inscriptions are serious. They can be cultural, they can be religious, they can be family imposed. But it's time to celebrate girls and women. And I close with a poem. One often closes with a poem. If we don't find one, we write it. But this one is by Rita Lloyd and it's called Masked. And I'm going to pull up a momento. This should be Masked. There we go. This is the masked woman. And here is the quick verse. At times I hide behind a mask, disguising who I am and the frailties that I possess. But then the voice of my spirit emerges and reminds me that we all are short of perfection, and that those who appear perfect are wearing a mask as well. So instead of hiding, I am prompted to embrace my imperfections with love. And with this inner self of self-acceptance, a radiance shines, surpassing any physical adornment I could ever possibly hide behind. So my sisters and brothers, let us respect, be attentive to, and try increasingly to prevent and service self-harm. Thank you.
Thank you, Louise, for problematizing this really complex relationship between pleasure and pain, indeed, and the subtext of that. And we are moving from self-harm and pain now to the power of sympathetic listening. So that may well be a very good trajectory to our final presentation, the power of sympathetic listening, and thus to the pioneers of reconstructive surgery. And so glad to welcome here Sebastian Krüger and Juliet. Without further ado, our final presentation, FGM Survivors' Quest for Wholeness. Sebastian and Juliet?
Yep, we're both here. Thank you very much for having us. I'll let Sebastian start and then I'll come shortly after him.
Okay. Hello to all of you. We're incredibly pleased to be with you today. We feel honored to be with you on this symposium because we are not experts like you are. We're just really interested in the topic of this symposium. Can you see me? Because I've had, as you know, incredible problems connecting as...
Yes, you're fine, Sebastian, please. Yeah,
okay.
Proceed. Thank you.
Maria, did you give us an introduction or should I do it briefly?
Do it briefly.
Okay.
Briefly, thanks.
Okay, well, I'm a documentary filmmaker and a television journalist, and my company is Krüger Productions. Juliet Wallace is my assistant. She's joined us and works in many fields and is an invaluable help to me. The reason why I asked her to join me is that she worked intensely on this film project of ours, which is on a pioneer of female genital restoration and the Institute Women Safe in Paris. But anyway, let me tell you, oh yeah, one more thing to our company. We specialize in cultural themes in the widest sense. So current debates and ethical themes are at the center of our attention, and we like to feature exceptional personalities that tell these stories. So just to give you an example, we did a TV film on Gilles Kepel's brilliant opus magnus called, just translated in English, called Away from Chaos, the Middle East and the Challenge to the West, which analyzes the roots of radical Islamism and the problems we're facing today. In a funny way, it is connected also to our subject, because even though we all know that Islamism and radical Islamism does not directly have anything to do with female genital mutilation, it has been encouraging it lately, and there's apparently new cases of this practice now in Northern Africa, but you know this much better than I do. So let me tell you how we came upon the subject. I read an article in an Italian newspaper, and a woman described the trauma she went through as a child, a case you're all so well acquainted with, you know, that she was led to a feast, and when she asked why all the girls were crying, nobody told her why, and she was led to a place where she was then pinned down by 3 women. A 4th woman cut her, and you know, and that was the moment where she experienced this incredible trauma, and this feeling of humiliation and shame, and the fear of sex, and the suffering that she then had till she was a grown woman accompanied her. Then she found the strength. This was all in this Italian article. She found the strength to deal with this problem of hers, and she eventually heard about Pierre Foldes, the urologist and surgeon, and went to see him and agreed to well, you know, had herself repaired, so to speak. She had female genital restoration done. So, you know, I thought this was really interesting, and so we started researching about Pierre Foldes and found out that he had been on humanitarian missions since a young man, always engaged all over the world, and because he also strongly believes that working in the field is the only way to really understand the problems that you are facing in these different cultures, and this applies to FGM just as much to other issues. And so on one of those missions in Africa, he's the pioneer of the clitoral reconstruction, as you probably know. He discovered this because he was treating a woman who was in great pain because of her because of the mutilation she had undergone as a child, and when he was treating her to help her, or when he operated her, he removed the scar tissue and discovered the clitoral organ, and this is where he then discovered what he could do, and he reconstructed it right then and there. Later, he then developed his technique, and the extraordinary thing is that, and this is scandalous really, that he discovered there was nothing about this in any of the anatomy books in the West, in our culture. He couldn't find anything about this. Only much later was this introduced into anatomy books. We then found out that Pierre Foldes has consulted over 10,000 women and operated more than 6,000. And the other thing that we then found out is that he founded this institution, this organization outside of Paris called Women Safe, which is in Saint-Germain-en-Laye, and he founded it together with Frédéric Martz. Here they treat all women that have been victims of violence, but including women that have been victims of FGM. While Pierre focuses primarily on the body, Frédéric, with her team of professionals, addresses the mind and social and legal issues. So the two of them are the 2 pillars of Women Safe. This struck me as really interesting because here it seems like for the first time they were approaching the healing progress in its totality. They have they have a holistic approach, because repairing a woman anatomically is, as we know, is just some of the way. The how do you say, what did I write here? The wounds that are left in the psyche, in the mind, in the psychology of a person have to be dealt with and treated with as well. And so we thought this would be really interesting as a subject for a documentary film, and also because, and it would contribute to the efforts and campaigns against FGM, because what we found shocking is that these figures you all know, 200 million women in the world, at least 200 million in the world, are supposed to be victims of FGM. And every year in Europe, 180,000 girls and women are in danger of being mutilated. In Germany, there's tens of thousands that are in danger every year. And this year, figures that have been published by the government show that the numbers have been rising again. So you know, a new approach, a new story, we thought would be really important. And I'll pass over to my assistant, Juliet Wallace.
Thank you for that introduction. So as Sebastian said, we've been involved in this project for a while, just over a year now, and like many of you that I learned today, we also visited the clinic in Saint-Germain-en-Laye. I'm going to talk a little bit about a bit more of context in terms of the female body. The name of this series of discussions is Patriarchal Inscriptions, Female Bodies Contested, Invaded, Defended, and Owned. And I think we have no doubt that FGM falls under the categories of invaded and owned. And we're having to defend them currently. And it's a practice, I mean, everybody who's involved knows very much about this practice, who's involved in the seminar, but just to be clear, it's horrific on a lot of levels when it's done without permission, which is oftentimes. And it happens to girls before they become women mostly, or before they're given the chance to become women mostly. And I think Nene had written, and we had spoken to Pierre and understood that many of the women that this happens to don't even know that it's happened to them, don't even know that their bodies are different, which is pretty shocking. It's something that I found very shocking. And it's something that Pierre and Frédéric work together to try and give a relative understanding of the context to the patients themselves, because sometimes they don't themselves know the context. But before Pierre could have developed the surgery he did, which Sebastian gave an introduction to, Pierre himself essentially discovered some extended element of the clitoris, which had up until then not been known. But it wasn't until 1998 that the full clitoris in its entirety was published or was discussed publicly by an Australian urologist, Helen O'Connell. And it was discovered to be a lot larger and a lot more sensitive. I'm going to try and share my screen now and show you an image of this. I think you can probably see my screen now. Can you see this? So this is what the clitoris actually looks like. And this was only really discovered in 1998, as I say, by Helen O'Connell. And this brings up a lot of other questions, which is, why did it take so long to discover the clitoris in its full, when there have been, in contrast to the male member, which has been written about extensively over centuries? And what does this mean in terms of ownership of the female body and in terms of women feeling like they have some sort of importance in their bodies? I'm going to try and close this now so that I can see your screens again. But this was very shocking to me, and as I said, this discovery had to be made and then published. It was only published in 2005, by the way. This is how late we are on getting the female anatomy out there. It had to be established, published, and understood before Pierre, for example, before his surgery could take on the way that it has. And since Pierre has been working since 1988, when he started his practice on this particular element of female reconstruction, there has been a spread of this surgery, but it still is contested a little by Pierre himself and by others, the extent to which the surgery itself is being used in the context of a holistic healing, which is what Frédéric and Pierre work together in Women Safe to do. But the holistic element of it, which many of you have talked about today, I think it was Marianne at the beginning talked about attitudes dominating medical practice, and this is part of it. And Toby was saying about the death threats that Pierre gets, and this is essentially attitudes dominating cultural practice. So what we're looking at is this contrast between attitudes dominating cultural practice and attitudes dominating medical practice. The ability is there. Pierre introduced the ability, and we have a surgeon here who uses the technique himself, but the difficulty is trying to overcome this subjugation of the female body, which continues to the point where Freud, who is still one of the most important figures in modern psychology, didn't believe in the clitoral orgasm. It was subjugated to the vaginal orgasm because it wasn't something that was meant to be able to happen from a woman on her own, which is very much linked to the idea that in FGM, a woman's body is essentially removed from her control and removed from her ownership. And in reconstructive surgery, and more importantly, in the other treatments that Sebastian's going to go into, Women Safe and the other people who are getting involved are trying to give back this ownership and this control, like our last speaker talked about. The self-harm is the other side of control, and in this case, it's trying to remove harm done by taking control and reversing it. So it's incredibly important, and we felt very much that Pierre's practice, Women Safe, with Frédéric was unique also because, for example, the NHS now is opened in September, a lot of new clinics to deal with FGM, but their focus is on defibrillation, which is more a practical side of dealing with the scars and the trauma that's happened to the woman. And it's more about giving birth and allowing penis entry rather than, some of it's about aesthetics, but it's much more focused on the practical use of the vagina rather than, and the vulva, rather than the emotional and female control over it. So that's why we felt that Women Safe was particularly important to discuss in a documentary. And I'll pass it back to Sebastian.
May I, as a chair, intervene here? And just very briefly, and that is, I have to consider the time. We've reached 3 o'clock, which is usually our cutoff point. But I know I will have the support of my colleagues, and I hope also of Taylor, our wonderful IT person, to continue. We cannot possibly end this, very rich number of presentations without also bringing in the questions that come from our very patient, invisible community of listeners. So if I could ask Sebastian briefly, simply to, outline, summarize, and then I would very much like to move to the questions in the Q&A box. And I hope I have the support from all of you for that decision. Sebastian. If you could unmute, Sebastian. You have to unmute. Sebastian, you're muted. Sebastian.
Sebastian, if you just, on the toolbar at the bottom, if you just hit your mic.
Sebastian?
The microphone with the slash through it, do you want to click on that?
Men and technology.
Okay, look, I'm so sorry about the technological problems, and I'm so sorry that I've missed a lot of the interventions before. I gather you've been speaking about a lot of the things that we're also mentioning. So I'll try and make it brief. I think interesting is, and you all know Women Safe. You all know the institution very well. Okay. Yeah. Well, yes. I'll just point out that from our point of view, it is interesting. Would be interesting to portray the institute, and you know they're treating 600 victims of FGM right now, and they've expanded their work in 2017. They now have, which is also quite important. They now have what they call psychophysical, or I would say psychosomatic treatments. They have osteopathy, special massages, and they have these group and collective activities, theater, yoga, cercle de parole, as they call them, a kind of group therapy. And all of this is very important. And their main aim is not to bring a woman to have FGR done, but to really understand if she's ready and willing to do it, and if she's, you know, because of the problems they face in their own communities, if they go through FGR. So they're not pushing for that at all. They're just trying to help, and their emphasis on prevention. So what are they doing now? They've opened also 2017. They opened their doors to children, to minors. And they try and go to families and involve the husbands, the men, because it's important to involve them in the whole debate. Another point I find important is that the treatments are for free. The government partly funds Women Safe, and then also have private help. But for the people, the women that are in need and go there, it's for free. I think that is also quite extraordinary. So I don't have to tell you about the other things I wanted to mention. Let me just tell you that, you know, we think that if there's any, you know, to round it off, we feel that it's worth doing a film on this institution, and we have a protagonist. I must say thanks to Toby Levine and Nene Bojan, who have helped us, who have supported us. But since we'd like to cover the problems that exist all over Europe, if it would be helpful, and you know, you may have some suggestions, it would be helpful if we could find protagonists from other countries, like from Germany or even England, because I remember Juliette and I were researching these new clinics that have opened up last year in England, where there are 4 women that have suffered, that are victims of FGM, but the reconstruction, as far as we researched, the reconstruction FGR is not even on the agenda, and it's not covered by the health service. So it's I can see somebody shaking. I can see you, one of our presenters, shaking your head. So correct me on that. But anyway, if we have another protagonist or two convening to Women Safe, we can cover different issues that are still important. And if you have anything new, anything that is useful in the struggle against this terrible practice, then please tell me. We know it's a cultural tradition, and that's why it is so strongly embedded. So it needs a lot of work. And if there are any new programs that are proving to be more effective, and if you have any protagonists that would be willing to be on camera as well, let us know. And thank you again for having invited us.